We are now on the chapter devoted to the spinal cord. Let me read vignette 17. A 52-year-old woman has constant, severe back pain for 2 weeks. While working on her yard, she suddenly falls and cannot get up again. When brought to the hospital, she's paralyzed below the waist. 2 years ago, she had a mastectomy for cancer of the breast. You know, most tumors affecting the spinal cord are metastatic extradural. And in this case, the source is obvious. She had breast cancer 2 years ago. Breast cancer has a propensity to metastasize to the pedicles of the vertebral bodies. And obviously, this has been happening here. This is what was the source of the pain she had. And then the pedicles were weakened to the point that in that movement she made while working in her yard, she actually broke her spine. Well, what are we going to do about it? Now, if you wanted simply to look at the bone, an X-ray would do it very well, and a CAT scan would do it even better. But in fact, what you want to look at here is the cord. You know that it's been damaged, and we want to know, is it transected or is it just compressed? And your best test to look at the spinal cord is MRI. So pick MRI for an answer. And then from there on, the neurosurgeons will be able to help if the cord is not transected. They'll be able to decompress it, and then the orthopedic surgeons may be able to stabilize the spine. Well, let's move on to the next. And as we read the next one, you're going to recognize something that we already reviewed. We did it in the chapter on orthopedic vignettes. We're going to review it one more time. The 45-year-old man gives a history of aching back pain for several months. He has been told that he had muscle spasms, was giving analgesics and muscle relaxants. He comes in now because of the sudden onset of very severe back pain that came on when he tried to lift a heavy object. The pain is like an electrical shock that shoots down his leg. It is worse with sneezing and straining. It prevents him from ambulating. And he keeps the affected leg flexed. Straight leg raising test gives excruciating pain. Now, you remember when we had this vignette earlier, that we said immediately you recognize right away a herniated lumbar disc. Let me repeat again the things that make it so characteristic. The peak age incidence is in the mid-40s. The nature of the pain has an electrical flavor to it, like this man describes. That pain is made worse by sneezing, coughing, straining, having a bowel movement. And so we know this is a herniated disc. Now we have a little added bit of information here. Since we're now reviewing the neurosurgical portion, let me point out that if the vignette were to specify how does that electrical, lightning going down the leg, how does it exit the leg? You may be able to tell exactly where the herniated disc is, because if the patient were to say that lightning exits the foot by the big toe, then the disc involved is L4, L5. But if it were to exit by the little toe, it would be L5, S1. Again, you might remember from our previous discussion that MRI is what is best for the diagnosis here, and that unless the sphincters are involved in the cauda equina syndrome or there is a persistent and worsening neurological deficit, that rest and pain control takes care of most of these. And let me add about the pain control, and this is something that we mentioned already and we'll mention some more. There is nowadays a very effective way to do this. There is a specialty where anesthesiologists have devoted themselves to the control of pain. They look at the MRIs, they see the nerves that are being compressed, and they can block those. They can inject long-term steroids, and they can inject medications to take care of the pain. And so it's much easier nowadays for patients to be comfortable while they are waiting for the disc to be reabsorbed by the body. Let us now move to vignette number 19. A 79-year-old man complains of leg pain brought about by walking and relieved by rest. On further questioning, it is ascertained that he has to sit down or bend over for the pain to go away. Standing at rest will not do it. Furthermore, he can exercise for long periods of time if he's hunched over, such as riding a bike or pushing a shopping cart. He has normal pulses in the leg. Now, when you first hear that an old man has pain when walking and needs to rest for the pain to go away, naturally, your first thought is claudication, intermittent claudication from vascular disease. But in intermittent claudication due to vascular disease, it makes no difference what position the patient is in while walking or what position the patient is in while resting. If you realize that there is that connection, the pain only comes with the exercise on a particular position. The rest and the relief come only in a particular position. Then we're talking about neurogenic pain. And this is, of course, ascertained by the fact that his pulses are normal. So this is neurogenic pain. The disease itself is called spinal stenosis. It is something we see often in old people that have a lot of exophytic growth of the bones, as it happens with age, that are eventually impinging on the nerves. This used to be a pretty difficult thing to manage and control until the advent of that new specialty of pain control. So what do you do for a patient like this? You do an MRI. The MRI is the best imaging technique to show those nerves and where and how they are being compressed. The patient is then referred to one of these pain control clinics. They will inject the affected areas and the pain will go away. We move then to vignette number 20. A business executive who's been a T6 paraplegic for many years is held at a business meeting for several hours beyond the time when he would normally have done his in and out self-catheterization of the urinary bladder. He develops a pounding headache, profuse perspiration and bradycardia, and his blood pressure is 220/120. This is a classic picture of what we call autonomic dysreflexia. This happens to paraplegics whose spinal transection is high. There has to be a lot of the body denervated for this to occur. Any kind of visceral stimulation could trigger it. In this particular case, it was a bladder that was full and overflowing. Obviously, in the management, we need to empty the bladder. But what has led to the hypertension is an alpha adrenergic output. And so we take care of that with alpha adrenergic blocking agents. Long term, he might benefit from calcium channel blockers. Now, before we go to the next heading, which is devoted to pain syndromes, let me show you a few pictures that we have for some of these issues we've been talking about. Here we have a picture of the spinal cord being compressed on the left, and then after the appropriate neurosurgical repair on the right. Something similar to this would have been what you might have seen on the lady that had the metastasis to her spine and then had compression of the cord. And here is a picture of a lumbar disc herniation. And here is another one of the same situation. And with that, we end the spinal cord.